Why don't we get started? Good morning, good evening, everyone. Today, our guest is Dr. Amit Parasnis, and the topic is something that a lot of folks have expressed interest in learning more about over time. So, we'll get into that. But before we do that, let's just quickly go through a couple of housekeeping items. Please type away your questions in the chat window. If you're not already a member of the Longevity Circle, it's free and it's a very good resource for you. So you can scan the QR code there on the screen, or Sneha will put a link to the community in the comment section, which he has just done. Every week when we have our sessions on the community, we post them. And a new feature that we added last week is you can just click on going and add to calendar, so that right through WhatsApp itself, the appointment can get added to your calendar, so you don't have to remember it. And the other resource that we have just introduced are these free 15-minute sessions once a week, every Wednesday at 9 o'clock India time. It's 15 minutes with Dr. Saurabh Sane, and he's finished, I think, 4 sessions so far. He's covered lower back pain, what are the exercises you can do to address it, vertigo, various migraines, and so on. And so if you can attend them because they're really helpful, they are simple, and it's only 15 minutes. And if you can't attend them and you're a member of that strength and mobility community, the link for which Sneha has just put in the comment section, you can get the recording of the session in 48 hours after the session is done. So reach out, join that community and join those sessions. I make sure I join them because I find them very valuable. Our speaker for next week is Dr. Samir Melankari, and he's a hematologist. So anything to do with blood is something he covers, and he will be our speaker and guest for next week. All right. To our guest for today, our expert is Dr. Amit Parasnis, and while a very shortened version of his bio is up on the screen, I'll say that, Amit is one of the most respected oncosurgeons in the city, and many of you may have heard of him or interacted with him, but for the others, you're in for a treat. It's going to be a very, very interesting, insightful session. So without further ado, Amit, welcome to the community podcast.
Thank you so much.
So Amit, let's start with the topic of, you've got into this field, you've been at it for a long time now. Of
Yes.
all the different specialties, what got you to become an oncosurgeon?
So the thing is, when you enter medicine after a certain period of time, when you're in your second year and you get an idea about what type of subjects you're going to study, that time most of us drift into 2 streams. One is a medical stream and a surgical stream. So I, for various reasons, I drifted into the surgical stream. And when you start liking surgery, you start the way you can treat patients with your actual skills, and then what you want to do is to operate big as in do bigger surgeries and make a difference to the patients' lives by with all your skills you imbibe. So then there are very few bigger surgeries than complex cancer surgeries. So like neurosurgery or cardiac surgery is probably bigger, but then oncosurgery is also right at the top, where you treat bigger cancers, you remove and reconstruct organs and tissues, and then patients get a new lease to life by virtue of your skills, and you tackle a deadly disease, and you get to support and treat patients from all walks of life. So that was the reason I mainly went into oncology, because it challenged my surgical skills.
Got it. That makes sense. And I noticed that, I was always under the impression, Amit, that the oncosurgeons focus on one specific area, but that's not true. In your case, you're doing it across all the different cancers. Can you talk about like how that comes about?
So the thing is, it's a matter of training now. Now you do have people, specializing into breast surgery. You have people specializing into gynecological oncology or head neck oncology. But these branches are yet blossoming now in India, at least. They are probably more established in the Western world. But as a surgeon, you get to train in all these specialties. I have been trained in treating cancers of all these particular systems. And so when I practice right now, I am focusing my practice on solid organ cancers. Although I must say I get to treat more of gynecological cancers, head neck cancers, and GI tract cancers. So eventually, say for a person who is entering surgical oncology today, training or practice, they will have to probably restrict themselves to a particular branch, say head neck oncology or thoracic oncology, and then people would, the people and hospitals would want to employ and get treated respectively by doctors who are specialized, say, in a few diseases, like say thoracic diseases or GI tract diseases. So the vertical split is getting more and more complicated now.
Yeah. And all the different cancers you treat, I mean, which is the one that you found in general to be the most complicated one?
So the complication of any cancer treatment depends on two things. One is the complicated anatomy when you are actually treating or operating on that person, and the second thing is the biology of the cancer. So I would say for both, as far as the anatomy or the complexity of the organ structure goes, and the severity or the aggressiveness of the tumor goes, I think lung cancer tops the list. I do also find esophageal cancer to be a very challenging cancer to treat, both as well as the anatomical part is concerned, because you have to operate in three areas, or at least two areas: the neck, the thorax, and the abdomen, in order to treat or operate on an esophageal cancer. And you have a very few weapons in your armamentarium to tackle esophageal cancer. Surgery is one of them. And then whatever so-called advanced techniques or advanced treatments, they are yet to be so effective in esophageal cancer. Lung cancer, the picture is quite better actually. That you have a lot of precision directed treatments which can work as first, second, third line treatments in lung cancer. So not so for esophageal cancer. So lung cancer, esophageal cancer are complex cancers and they are challenging.
Got it. There are so many questions as you were saying this that were coming to my mind. But maybe we start with the basics of, we all hear about cancer, but nobody really understands exactly why it happens. I mean, at a high level, people have made statements, but if you were to explain to somebody, Amit, like, what is the biology of cancer? Because it starts with one cell and then it spreads. Can you just explain that to the common man?
Yeah. So when we say cancer, now here I will restrict myself to solid organ or organ cancers. Hematological cancers also behave in a similar way, or the theory may be also similar, but then when giving examples here, I will restrict myself to organ cancers, say breast or kidney or any organ in the GI tract, say stomach or rectum. So what happens is, this is strictly for a layman. I mean, I'm sure you
Yes.
must be aware with all these terminologies and things. But for a layman, when you try to explain things, that every cell in our body has got a particular life cycle, and the cells, group of cells form tissues, and tissues are ultimately arranged into organs. And whenever the cell does not follow its life cycle and behaves erratically, then there is a problem, and there are some diseases which you can expect to develop. So what happens is, when the cell is expected to perform its function for a number of days, particular number of days, and then it's supposed to die. The cell death is called as apoptosis, so that new cells are generated and the organ keeps on doing its function. But so supposedly Suppose if a cell does not behave according to what it has been programmed to behave, and starts functioning erratically or starts dividing rapidly, it will soon form a lump of cells or clump of cells, which will develop into a tumor. And that tumor, since it has dividing cells and it will derive blood supply from the organ itself, and then it has a potential to damage the organ, grow in the organ, and spread potentially to other parts of the body. This is how, in simple layman terms, a cancer develops. And why the cell has to develop or has to behave in this erratic function, that can be so, I mean, it can be a topic of discussion, and there can be various etiologies to that particular thing happening. And many a times we are not able to pinpoint in a particular person or particular patient why that thing happened. That it can be because of various reasons. It can be like genetic, it can be environmental, it can be toxins, it can be trauma, it can be repeated infections. So there are various things, and for different organs, it can be different.
Yeah. And I think this is the part that often is scary to people is nobody knows what they did wrong in their
Right.
mind
Right.
that caused it. And then there are people who will point to someone else and say, look, he's doing all the things that you said not to do. He's not getting cancer. And I did all the things you told me to do and I got cancer. And this, what seems to us like randomness today, and hopefully in the next 5, 10, 20 years, we understand what exactly is causing it so we can do that much more. But that seems to be the biggest challenge, right, Amit? That how to explain to people what they did wrong that caused the
So,
cancer.
interestingly, I get a lot of patients. I mean, fortunately, still cancers are, seen in the later years of life still. So I see most patients beyond 50 or 60 or 70. And although you do have patients, younger patients presenting with cancer, but most of them are, say, 60, 70. And then I get quite a lot of patients telling me that, this is the first time they have come to a hospital. This is the first time they have had to get admitted in the hospital. This is the first time they're undergoing any surgery. Some of them do not have any comorbidities. Most of them do not have any addictions, and still they would get cancer. So it's a difficult proposition explaining them that people who can who do all sorts of use all sorts of abuse all sorts of substances, they don't get cancer. And sometimes even if you are a teetotaler or a non-smoker, you can still get cancer. So it's not that something which you did or something which you have not done will cause cancer. We still don't know exactly why that thing happens. Interestingly, and again, there was something proposed in many years ago, which is called as a two-hit theory. You have two tumor suppressor genes which need to be damaged in order for the cancer to be caused. And if you have a genetic predisposition, one of them is already gone, and then if one more somatic hit you need for the cancer to develop. And if you don't have a genetic predisposition, you need two hits simultaneously for the cancer to develop. So this two-hit theory can explain why cancers occur, and they can occur even without any so-called dietary or substance abuse or any other illnesses. They can even happen in an apparently healthy person.
Yeah. And this leads to a very difficult conversation, because then the argument that is made is, see, if this is the case, why do I have to worry about doing anything on the preventive side? Many cases not in my control. But that's also not completely true, because in this two-hit theory that you just explained, that second hit, if you don't live a healthy lifestyle, you're just increasing the probability of that
Right.
second happening, right?
Right. So correctly, as you said, in order to for the cancer to develop, and in absence of a genetic predisposition, you have to have two hits at the same time, somatic hits. So if you don't maintain a good lifestyle, if there is substance abuse, or if there is something which is not healthy in your lifestyle, or your in the way what you eat, the stress levels or whatever, that can predispose you in some way. But then again, we cannot really say that that is going to be the cause for cancer. We see so many people not bothering to improve their lifestyles and not getting cancers. Or but then again, it is something of a genetic thing, so we cannot really say what is going to happen. But herein comes the role of your preventable factors like diet, nutrition, sleep, stress. All these factors come into play in preventing that second hit.
Right. Right. And there's that saying, Amit, which is, genetics loads the gun and lifestyle pulls the
Right.
trigger. In some sense, those are the
Yeah.
two hits, right?
Correct.
If you are unlucky and your genetic is already loaded the gun,
Correct.
there's the first hit. And then your lifestyle, you make those incorrect decisions.
Correct.
It's not deterministic, but probabilities do go up.
Right,
Right.
definitely. And with newer technologies now, you can find out what type of disease you're at risk of, and then you can modify your lifestyle accordingly. That's fortunately, it's not so unusual now to have people doing their gene sequencing or NGS, and then finding out that they are predisposed to diabetes, so they can take care, or they are predisposed to kidney disease, so they can take care, or maybe certain type of cancer, so they can modify their lifestyle accordingly.
Yeah. In fact, it's interesting you mentioned that, Amit, right? One of the things that we are hoping to launch in the next month or so is, today people do their blood tests maybe once a year. And that's their only window for most people into whether they're healthy or not.
Correct.
And that will tell you more about heart disease, metabolic function, and so on. The cancer aspect is not often seen in a blood test report unless you measure every possible parameter. Even then, it's not clear. But now what we are doing is we are saying, let's add the exome, okay, and do the exome, which is a one-time test, along with a blood test, and maybe even something like a pharmacogenomics test, so that together you now have a picture of, is your gun loaded because of your genetics, and is it translating somehow into your blood test parameters as well. Now you have a much more broad and overarching view of whether you're increasing your chances or not. So that's definitely interesting. When you look at the lifestyle factors, Amitav, that you personally would say, look, while there is no guarantee of anything, here are certain things definitely focus on from a lifestyle perspective to reduce the probabilities. What would they be?
I think first and foremost would be staying away from any addictions. Tobacco in any form, alcohol in any form, and some sort of I would say extremes of food habits in any form can be damaging in some way to the body. Now, this is very difficult to explain and pinpoint with respect to a particular organ or particular food. But then, more or less, if you stay away from the extremes, that does not mean you should not touch alcohol at all. Or I mean, I would recommend that you should not smoke at all, or you should not use tobacco at all. Alcohol, the same thing. But then, if you want to take a certain celebratory drink of alcohol or something, that is not what I'm talking about. What I'm talking about is maintaining a lifestyle of extremes, extremes of addictions or substance abuse. That is the one thing which you can easily stay away from. That is one thing. And then comes the the lifestyle changes which are responsible for not only cancer but lots of other metabolic diseases. And then now we in some way know that cancer is also a metabolic disease. The metabolic theory of cancer is a better understood theory than probably the genetic theory of cancer, because most cancers are sporadic and not genetic. I would say around not more than 5% cancers are genetic or hereditary transmitted. The most 90 to 95% cancers are sporadic cancers, and sporadic cancers are because of these whatever metabolic changes in the body which occur because of your health and because of your diet and because of your lifestyle, because of your stress. A lot of factors go into it, comorbidities, existing comorbidities. So all these factors are modifiable factors, and if you pay attention to them, you would decrease your risk of getting cancer as well as any other metabolic diseases also. So paying attention to them is important, and not stretching yourself to go to extremes of those particular spectrum is very important.
Yeah, that's actually very simple but important advice. Uh, Moderation, as they say, is always key,
Right.
and I think this is a perfect example of that. What about the role, Amit, of exercise? Is it clear that exercise, I mean, for metabolic diseases, exercise has a pretty important role. Would you say the same is true for cancers?
Yes, in some way. So it's like not that that you are, if you're exercising regularly, you will not have heart disease, or if you're exercising, you will not have cancer. But then in some way, it will help you to maintain an ideal body weight. It will prevent obesity. Now, obesity means again hormonal imbalance. Obesity means secretion of cortisol, unregulated secretion of cortisol in the body. Then that affects the immune system. So you don't want to have a hyper immune system also, which will actually come in the way, or which will actually not be very conducive for cancer growth. And you don't want to have a hypoimmune system also, which will make you more susceptible for cancer. So you have to have a balanced immune system, and all these parameters like obesity or diet or stress will lead to an imbalance in the immune system, which will predispose you for cancer. So all that, some people say that stress may cause cancer, or a negative attitude may cause cancer. It does not really cause cancer as such, but then it creates an environment in which, if you add substance abuse, if you add poor lifestyle habits, if you add poor diet, then that will probably add fuel to the fire.
Yeah, yeah. And as you were saying this, I was thinking uh, to keep your immune system in check. One of the parameters that's always measured in blood test reports is your HSCRP, right? Are there parameters like that, Amit, that you tell people, look, while a report might have 120, 60, 80 parameters, and they all matter, which are the 3, 4, 5 that you tell people, keep an eye on those?
So unfortunately, cancer does not occur in one organ in the body, and so you can't, as we said earlier, you can't have a blood test which can detect cancer. And tumor markers, at best, most of them, if not all, are useful in prognosticating a cancer, or when you're trying to gauge the progress of cancer or its response to treatment. So they may not be diagnostic, although they may give a hint. So depending on each type of body organ you have, you can have different types of tumor markers, which uh, not as a screening or a checkup, apart from say PSA or some other one of say CA-125 for ovarian cancer. You cannot have this blood test as a screening modality or a screening pattern for cancer. You cannot have that, unfortunately. It's not like, say, you do HbA1c for your glucose or for your diabetes, or you do your creatinine for your kidney, and then you can monitor it and check the health of the organ. That unfortunately won't be possible. Although PSA, that is prostate specific antigen, after a certain age in men, might be a good screening screening blood test for prostate cancer, which is also now growing common in Indian males also. So apart from that, you don't have any screening tests as such, blood tests, which will show that you have a predisposition for cancer, or which will diagnose cancer.
Yeah. So, of late, now this has come under some sort of scrutiny of recently, but this Grail test from Gallery, which is a blood test, and they have claimed that they can look at 50 cancers at the same time. On one hand, it's a very amazing sounding test. On the other hand, when the NHS did this big trial, they could not show that led to fewer deaths. And so I know that test is not available in India as yet, but Amit, have you seen more, read more about this Grail test from Gallery, the Gallery test from Grail?
Not that maybe, but we do understand about circulating tumor DNA or circulating tumor cells, and those tests are really available in India also, although at a cost. But then again, we have not been. I think they have been available for quite a few years now, but we have not been able to prove their importance or clinical significance in clinical trials. And especially as far as India goes, it is very difficult to have any screening guidelines because of the sheer number of population which you need to screen, and the cost effectivity, cost constraints.
Yeah.
So screening for cancer, uh, everyone knows like mammography or pap smear or PSA. That to a certain extent you can, and for a certain number of cancers only, you can have some tests for that. But then for a population-based screening or for even for individual screening, the constraint for population-based screening is the number of people and the cost, and for individual the relevance of the test. That is the constraint. So like as you said, it cannot be as we go by evidence-based medicine, and if you cannot prove it by or you don't have a substantial evidence, level 1 evidence with a good randomized trial or several good trials, you cannot really bring it into practice,
Yeah,
because again practice is governed by uh, the cost, and cost is, to a certain extent, it gets divided into the individual person and the insurance companies, and then all those different politics come into play.
yeah, no, that's true. And like for example, we did a cervical cancer screening, HPV screening program for women in rural areas, and we use CSR funding to make it available. Otherwise, again, it gets expensive to do
Mhm. Yeah.
DNA tests. But we were able to screen about 30,000 women through that,
Mhm.
and 8% of them had reasonably advanced levels for which they required treatment. But
Mhm.
now to make this India wide
Mhm.
is a whole different beast. But today, if you had to tell people, here are 3 or 4 screening tests you should do because they're reasonably affordable, especially for people who are on this type of call, would it be the mammogram, the uh, cervical cancer, HPV test, the PSA? Are those the three
Yeah,
or
I
four?
think that's just it actually. So
That's it.
yeah, apart from that, I would say uh, getting a colonoscopy after the
Hmm.
age of 50 for both males and females uh, should go a long way in early detection of colon cancer, because colon or rectal cancer is one that does not present in early stages or does not cause any symptoms in early stages, and has a very good prognosis if treated early, and very less changes in lifestyle would need to be made if you get operated early or get treated early for colon cancer. So colon, breast, and cervix, uh, and maybe prostate, these are the tests which one should get definitely done after a certain age, although they can't be used as a screening modality apart from mammography or pap smear. But yes, these tests can be done at an individual level, periodically once a year, in order to make sure that if there's something, you catch it early.
Right. And one thing that I've recently even written about is that the data seems to suggest that lung cancer, 25-30% of them are happening in people who have never smoked.
Right.
Is that something you are seeing, and what can one do about that?
So that's a very interesting thing. Adenocarcinoma of the lung is seen in female non-smokers, and the incidence is growing. You can attribute it to pollution, you can attribute it to lifestyle factors, you can attribute it to chronic infections, you can attribute it to comorbidities, but it is here to stay. So you cannot always say that staying away from addictions is going to prevent cancer. You can have cancers, and especially lung cancers. And lung cancer, sometimes it's very famously related to smoking or tobacco usage, but you can have lung cancers without that also. And yes, we do see alarming number of women and other patients also with lung cancer. In fact, lung cancer is on the rise in India, and the problem with lung cancer is that it's a complex anatomy. It's a very vital organ, and it is often detected in later stages. So that curative intention might not be always there when you treat lung cancer.
Yeah. Yeah, this came as a surprise to me. Like I wrote about this in my blog post because about 6-8 weeks back, I ran into a friend who had it, but has never smoked, is not even around secondhand smoke. And then once I started looking into it, the points you made came out, which is women, especially in the developing world, are the ones who are most prone. And like that came as quite a
I
surprise.
recently lost a close female relative, elderly close female relative to lung cancer.
Again,
Never,
non-smoker.
adenocarcinoma, never smoked. Stayed in the
Wow,
city, stayed in the city all her life, but
amazing. Yeah, Yeah. The other thing that I've also been hearing a lot about, Amit, is in the US at least, and I don't know if it's true in India, the rate of colorectal cancer is happening, is the only cancer that's increasing in numbers and in, per thousand. But it's also happening in younger people. Is that your observation? Is that true in India as well?
Certainly. See, as we copy the lifestyle of the Western world, and as we are urbanized more and more, we are going to have a similar disease pattern. And we are already doing that in cities. The cities are not far behind from the West as far as diet and risk, lifestyle and stress are concerned. And so we do see a lot of colorectal cancers, and we also see a lot of young colorectal cancers below the age of 40. And they do have a very not so good prognosis. They are aggressive, and it is very difficult in that productive phase of life. The career, the family, everything is at a level which, when it gets affected, it's going to have a big impact on not only on the individual but also the family. So that is a big problem, and we do get patients in their early 40s, early 30s with colorectal cancer. I recently saw a lady with she was 34.
Oh. Wow.
So that is a similar pattern to the US, which we are seeing, increasing the number of breast cancers, ovarian cancers, and endometrial cancers rather than cervical cancers in city living people, women. So that's a change from the previous scenario where cervical cancer was more in India. Now breast cancer has replaced it. I used to operate at certain semi-urban, or not exactly rural, but semi-urban tier 2 cities. And I can, in the past 20 years, I can see that pattern of increase in the number of endometrial and ovarian cancers and breast cancers, and a drastic decrease in the number of cervical cancers.
Yeah. I want to just share one thing that a recent experience, Amit. There are, of course, all these influencers talking about things on Instagram and all of that. One of them, who's got a pretty big following, recently said that the entire cervical cancer thing is all a hoax. There are very few women, if any, in India who die of cervical cancer. And his claim is that Bill Gates did this because he wanted to get his vaccine that Gavi funded. I mean, on one hand, we have seen these conspiracy theories, often, but the fact that they are now coming from people who are in positions of power and influence is scary, because when I saw that post, on one hand, I just rolled my eyes and said, one more weird conspiracy theorist. But when I saw the comments, because so many people follow this guy, their reaction was, "Oh, good, you told us. Now we are not going to vaccinate our kids."
And so the thing is, I don't know, I'm sorry to interrupt, but the thing is that, as in US or in India, when you see a doctor or when you go to a hospital, it is not a very pleasant experience. And then sometimes with the type of world in which we live, I think the trust is gone. The trust may not always be there. It will come when you visit the doctor twice or thrice, when you talk to him, when you understand what he's saying, and when you realize that he is not there to fleece you out of your money. And the hospital also is going to charge you reasonably, and there to be of service to you. That is the time when you have trust. But then more or less the trust factor is missing, and so all these theories come up that hospitals do it for making money, or insurance companies are there to make money, doctors are unnecessarily operating patients, or this particular disease. I mean, that's the funniest comment I've heard, that it's a hoax for only vaccine production. That's the funniest comment. So that sometimes happens out of mistrust, I think.
Yeah. No, I think you hit the nail on the head. I mean, that's exactly what I've seen, is because there is, and this is across the world, trust in the healthcare system has gone down. And like in every profession, there are always some bad actors. But then everybody gets painted with that brush. And in the world of social media, it's very easy to now use that to build your following.
Right. So that should not be the case. I mean, you do have good people also on Instagram and wherever people go to get their podcasts. They do have good I mean, who are not medical people, but they do study like you, I guess. I mean, but you do have a medical background. So even without that, people do study and have go to great lengths to give proper authentic information to their listeners. That can happen, and then you have people like this at the other end of the spectrum.
Yeah. And in many ways, that's why we started this community concept is
Yes,
that
yes,
let's have experts like you come share the what actually is the truth so that
right,
people should feel like this is their one-stop shop for the truth. Right.
right.
Um, the other question I had is, I think Deepa, you're on off mute. Can you please go on mute? There is now more and more treatments, right? Therapies that are coming in, which I think on one hand has reduced the number of deaths that would have otherwise happened maybe 10, 15, 20 years back. What are such treatments, that are exciting from your perspective, because you've seen the evolution over the last 20, 25 years? What are the changes that are coming up that are worth noting?
So it's not only newer therapies, but it's also understanding of the cancer pathology and understanding of the cancer behavior, which has also changed our treatment paradigms in many cancers. So for example, we now know that treating a cancer with radiation in situ, when the cancer is in situ, is much better than treating the cancer with radiation after it has come out. So like it has made a difference in diseases like cancer esophagus or cancer rectum, or even cancer cervix, where we want to radiate the disease when it's still there. We want to sterilize the margins when we need to resect the tumor. And this has led to change in the sequence of treatments. So this has happened over the past 15, 20 years, 15 years, that we have changed the sequence of treatments in esophageal cancers and rectal cancers to what we call as neoadjuvant or preemptive or radiation given prior to the definitive treatment, that is surgery. So this is a better understanding of the disease biology and the disease behavior, because you will have lesser recurrences and better overall survival if you treat the patient with radiation before you operate the patient. Same goes for chemotherapy in, say, ovarian cancer or breast cancer. That you now know that instead of doing heroic surgeries, if you downstage a tumor by giving chemotherapy, you will be able to do a better job surgically, and the patient will be benefited by that better surgery as far as recurrences and overall survival is concerned. So that is one thing. And then now we have, we try to treat the tumor according to what is driving the tumor, rather than only the histology or only the site or location of the tumor. So there are certain biomarkers or receptors on the tumor which can be measured, which can be detected. And you do have identifiable targets in most cancers, especially for, say, breast cancer or lung cancer or colorectal cancer. And these identifiable targets will enable you to use medicines which will act only against these receptors which are present on the cell surface. And we will try and go and specifically try to kill the cancer cells. That is, of course, the ideal situation. It may not happen all the time and in all, say, 100%, but more or less it has improved the outcomes of as compared to traditional chemotherapy. So this is what we call as targeted therapy. We have different targets which are nothing but receptors on the cell surface. And then now we have something called as immunotherapy, where the doctors would try to sensitize your own immune system to handle or battle with the cancer cells in the body, which are actually recognized as your body cells, and the immune system does not attack them. So you can have certain medicines, certain therapies which can train and enable your immune system, your own immune system, to tackle the cancer. So all this has definitely made a difference in the survival of cancer. And more than that, there are different options available now. So initially, say 30, 40 years ago, maybe 50 years ago, you would have only a limited number of options for treating cancers. But now you have first line, second line, third line, fourth line treatments, which may be effective, and they would reasonably prolong the life, reasonably give a good quality of life, and in some cases may even cure the cancer in advanced stages.
Yeah. So, Amit, one of the challenges, and because I've had both my parents go through it, the whole cancer journey, I realized two things. One is because there are so many options, right, versus the past, which on one hand is a good thing, but on the other hand, you almost require someone to guide you through it. Okay?
Oh, yeah.
And that I've realized is easier said than done because not everybody knows all the options as well. And I'll tell you, for example, with my mother, uh, she went through chemotherapy. She was told that because the tumor was in a slightly weird position, this was for breast cancer, that they recommended not doing surgery. Um and so it was chemotherapy and radiation. Then she was told immunotherapy because these two did not work. But in her case, and of course, this is 8 years back, and since then a lot has changed. But I don't think the fundamental problem has changed, which is she was recommended immunotherapy, but the immunotherapy in her case caused her immune system to turn against her healthy cells, and that accelerated her downfall. And so, if I were to go back in time, what would I sort of think about doing differently? And that is, I would want to talk to someone who understands all the options well versus at a surface level. And today, I would imagine that that's still the biggest thing is who's the trusted person you can go to who can give you an overarching view. I know who it is supposed to be. It's supposed to be the oncologist, but I'm not 100% sure that they're all the same, and there has to be some way to differentiate.
So let me tell you, this is more of a philosophical question, and I will try to answer it in that way only because it's a philosophical thing. What you said is a paradox of choice. Now you have so many information sources at your disposal that you get a lot of information, and if you are, say, indeed, inquisitive enough to look up all those sources and try to get some information, you'll be bombarded with a lot of information, and you will not know what to do with it because information is one thing and action on the information is another thing. Now, again, traditionally, cancer used to be treated by surgeons. At least solid organ cancers mostly used to come to surgeons. But now with the emergence of medical oncologists in the past 50 years, as a medical oncology as a specialty, it developed in 1940s. So it's hardly 78, 75, 80 years now that we have this specialty. So with the development of that specialty, now that and awareness in the public, people do go to medical oncologists also, and it's not a bad thing at all. They are very well versed in their field. But the thing is, what happens nowadays with most medical fields is that people feel that the latest thing is the best thing. Now again, you may call me old or you may call me old-fashioned, but when you see and when you have treated a lot of patients in a certain way, and when you have had good results, you would not want to change that particular pattern of treatment just because some new study says that this is good or this is here is a different drug for you to try. Now there has to be something which is called as keeping some treatments in reserve for cancer, and using the situation has to be judged in a particular way, wherein in some cases you reserve treatment and in some cases you go all guns blazing for in the first instance because you have an aggressive disease. Now the decision of doing this or that depends on experience, and experience is something which is shunned by evidence-based medicine. But then I always tell my patients, statistics is for the masses. For an individual, it is either 0% or 100%. So for an individual, when you think at that level, you should trust the experience and not only the evidence. So the experience of the person, the age will decide that, the training will decide that, should actually be the driving force behind decision making. This is what I feel.
Yeah, no, I think that's great advice, Amit. And interestingly, I was reading an article yesterday. There was a big study done of about 7 million people, okay? And they were looking at, does the age of the physician matter? Okay? And it was an interesting study because it said it depends. for certain things like cancers, okay, where experience gets built, the 5,000 surgery you do is more interest or more is better than the 500 surgery. And so for things like cancer, the older the physician, the better the outcomes. But for
Yeah.
certain other things, because things are changing rapidly in that space, then the younger is better. So there isn't a question of old or young. It really comes down to who keeps up.
Yeah,
That
and of course, it's not like, as we said, it's not like the extremes. There has
right.
to be a middle path somewhere. So you have to be a experienced enough physician or a doctor with good enough knowledge to keep up with the latest advances, and be able to offer a judicious choice or judicious mix to your patient. So
Yeah,
that's all those things have to come into fall into place.
correct. Exactly. I think it's that whoever keeps up with what's happening is the one who will be able to provide you the best guidance. And that is, I mean, one of the things that I always admire is, doctors like you're doing a ton of surgeries, but somehow you are expected to find time to keep up with the latest advances and trying to do, because the first gives you practical insight, the second keeps you up to speed. To do both is hard, and that's why the number of people you can go to who will give you truly wise advice is not that large.
Sometimes I have to tell my patients that this particular tumor does not require, or other, if I don't operate this tumor, and if I give chemotherapy and then operate, you have a better option. And I have to tell them that even though I am a surgeon, I am not going to operate you first, or I'm not going to offer surgery to you first, because if you have a hammer in your hand, everything looks like a nail. That should not be the situation in your case. And then I have to convince people that I'm not telling you to go for chemotherapy because I can't operate you. I'm a competent enough surgeon, but results of your tumor after operating, after giving chemotherapy, are better, and that's good for you. That's why I'm suggesting surgery for chemotherapy first for you. I have to convince this to patients, and then again that comes because you know what is best now. A patient whom I would have operated 20 years ago, now I treat with some other modality, and then I operate. That happens.
Yeah. And I just want to make one comment, which is, for people in the community, one of the reasons that I really wanted to speak to Amit is he has a reputation for being the way he just spoke about it. While you are saying this right now, Amit, a lot of people have spoken to have said this about you, right? And that to me is a great sign that there is trust, and that trust comes because you could have taken the person on as a patient and you said, after you do this, because then the chances are higher. And I think that's the type of people we want on this community podcast. You help us increase our trust in the system, but also when each of us, I think right now cancer touches everybody, whether directly or family member. It's no longer something that happens 3 connections away. It's now 1 connection away, and that is the scary part, right? In terms of moving forward, I mean, there is stuff happening now on the horizon. Do you see anything new? Like, gene therapy is a hot topic, and it's been a hot topic for a while, but for a long time it didn't seem to translate into anything real. But of late, it seems to be showing results, especially in things like genetic disorders, right? Spinal muscular atrophy and so on. In cancers, do you see gene therapy playing a bigger and bigger role?
So the problem with scientific advances is that science moves at a greater pace than it can be actually applied to the for your practical applications, or for applications to people or patients in general. So like you may have gene therapies, or you may have different types of therapies. Even as you said, immunotherapy and precision oncology, it's still and it's still in the making. You cannot say, when targeted therapy came first, say around 20 years ago, people are very excited that now we have targets on the cancer cell membranes, and now chemotherapy is not going to affect the other growing cells in the body, other dividing cells in the body, and it will only affect the cancer cells, and we'll have lesser side effects and better results, and more tumor controls, and less deaths. and unfortunately did not translate totally into that for reasons which are very difficult to comprehend. You may have tumor resistant, or treatment resistant clones developing in the tumor itself, and 2 plus 2 may not always translate to 4. So that can happen. So all these therapies are there. Maybe the West is around 10 years ahead of India as far as the availability and the practical applicability of these treatments is concerned. But this progress and the effect which is caused by this progress is happening with a very slow pace. So the pace of the discovery is fast. The pace it goes like a drug discovery. So you have a drug which shows some promise in a particular situation, but getting that drug into actual practice into patients after clinical testing through various levels of clinical trials takes a few years. So it's that way. So this is going very slow. What we would right now, what I try to tell patients is, I mean, this may not be acceptable for all, but this is what is real practical thing going on. That try to go with the standard treatments first. Try to go with the standard state-of-the-art treatments first, and very, very experimental or advanced treatments can come later, because we don't have enough evidence, we don't have enough wherewithal to understand all the implications of these treatments. So for people who have standard cancers, if we use standard treatments, we have standard results. We have gotten standard results. So sometimes we need to keep these treatments in reserve. We cannot use all our weapons at the same time, all our whatever available avenues at the same time. We need to keep some things in reserve. Some things, it can happen in the next, say, 25 years that this can become a first-line treatment. That can change. It takes that much time to change. For a paradigm shift to occur, it will take 20 years.
Yeah. And I think to support your point, the 5-year survival rate of various cancers, including breast and all of that, has gone up significantly, which says that what is being done works. Now,
yes,
to get the newer things, that should also be done at the right pace. To your point, otherwise,
looking at a parallel situation in surgery, when I was training, say 25 years ago, it was all about open surgery in cancer. Now, we would look first and foremost for minimal access options or minimally invasive options. Most of the times it would be possible also. We would look at organ conservation. We would look at lesser surgeries, lesser extent of surgeries. It is possible, and it has been proven to be equally efficacious also. So that paradigm to change, it has taken 20 years now, that we are looking at those options first, and only if they are not possible or not practicable, then we go for standard radical open surgeries, organ removals, etc. So that has changed in surgery. It has taken 20 years. So these advances in oncology will also take a span of few years for becoming standard of practice or becoming coming into first line of practice.
That makes complete sense. I know we're running out of time. I'll ask one question and then open it up to any quick audience questions. Once a person has cancer, Amit, there is a lot of talk that I've seen, read, that, and I don't know whether this is true or not, and I want to get your take on it, is one school of thought says that if you've got cancer, then starve it by having much less sugar, right? Is that true or is that not true?
It is, of course, not true, because whatever you eat, ultimately, when the tissues undergo respiration, the respiration at a level of tissue level or cellular level is always glucose plus oxygen giving you energy plus carbon dioxide and water. So all your nutrients are ultimately transformed into glucose only. So starving yourself out of excess or additional sugar may be good for your diabetes, may be good for your metabolic disorders, but it is not going to make a hell lot of a difference to your cancer. Well, it's going to get its sugar from somewhere else. It will take the proteins from your body, it will take the proteins from your muscle, it will take the proteins from your liver, convert them into sugar and use it to grow. So starving a cancer will not be a good means or a sure shot means of treating cancer. That is another Instagram myth, I would say.
Yeah. Yeah.
So
Thank you for
yeah,
you are busting it.
most of the people who undergo treatment for cancers are in a catabolic state. They surgery, radiation, chemotherapy, target therapy, whatever therapy, the body is in a catabolic state. It is being bombarded by uh, drugs which are going to kill some of its dividing cells. They are going to cause a change in the metabolism. So body at this time requires more proteins and more calories. That is the type of diet we should take. And then unfortunately what happens is people don't have enough appetite, people have nausea, people have vomiting. Certain cancers will not allow you to eat also, like say esophageal or stomach cancers. So
Right.
nutrition should be good. There is no point in starving a cancer. It is not going to starve, it will find food for itself.
Yeah. That's great insight. So let me go to quick audience questions, Amit. Uh, Thank you, Dr. Amit, for valuable perspectives. While it is good to know about elective lifestyle to reduce probability of second hit, can you comment on other risk factors which are blind spots for majority of the population? Example, chemical exposures, phenols, viral infections. What should ordinary citizens living moderate lifestyle should be aware of real risk?
So I have a very good sentence for this, that uh, there are a lot of things which are going to affect us when we are in the out in the world. The air is going to affect us, the water is going to affect us, people around us are going to affect us, what we eat is going to affect us, what we are not eating is going to affect us, what we do is going to affect us, what we don't do is going to affect us. So we should just take care of the macros, and the micros will take care of themselves. This is what I feel. You cannot be perturbed about microplastics in the ocean or dissolved pesticides in your water, groundwater. You cannot do anything about it.
Right.
You should rather focus on what you can do, like say eating simple, healthy food, maintaining a good exercise, doing exercise, maintaining a good lifestyle, maintaining an ideal body weight, taking care of your personal cleanliness, personal, all organs need to be clean, the body needs to be clean, staying away from addictions, having a good mindset, being engaged, and having interest in people around you and in the society, doing good things. So all these macros, if you take care, I think somewhere the micros will take care of themselves.
Yeah.
And if you are in a anxious state, like what happened with me, I can identify with whatever the tone of the question was. When I started reading a lot about diet and different types of diet and whatever, then I found that every diet has got some problems with it. So you cannot eat wheat, you cannot eat sugar, you cannot eat dairy. What are you going to eat then? So like if you exercise moderation and take care of the macros will probably take care of themselves. This is what I would like to say.
Yeah. By the way, I completely agree and buy into that philosophy. And that's why, like, everywhere in moderation, if you can avoid the extremes, like you said earlier, right? Usually, so avoid the extremes and control the controllables.
Correct.
I think
Correct.
that's really.
Yeah.
Kedar had another question. On colorectal cancer, an interesting insight I learned was that Kerala seems to be leading in rate of incidence, potentially linked to higher amount of red meat consumption. Is that something, again, red meat, have it in moderation or avoid it if possible?
So there has been a talk about meats as such, how good or how bad they are. And again, having it in moderation is not going to be bad for you. Any sort of meat, red or white or fish or whatever. Having lots of vegetables and fruits, fresh fruits, to some degree, it might give you some protection against colorectal cancer. And having a lot of red meat will give you some predisposing risk for colorectal cancer. So the less you have it, the better. This is what I can say.
Yeah. Yeah. And that's in line with what I've also been sort of looking into is reduce it. You don't have to avoid it, but reduce it and have enough fiber in your life.
Right.
Amrita had a thing, in discussing cancer, it is refreshing to hear journeys being used versus battle with cancer. To me, it makes space for responding in healthy stride as opposed to a reactive response.
So I had written somewhere before that, I had written an article somewhere, a philosophical article somewhere, that why do we say that one is battling cancer? And when diabetes gets diagnosed, no one asks how much the patient is going to live. what's good now. I'm battling with diabetes. No one says that. People just ask, okay, what needs to be done, what dietary modification, what medicines, and then move on. So with different treatments, with different interventions, and with precision oncology, now cancer has become a chronic disease. Now your say a lung cancer patient can have up to 4 or 5 different lines of treatment, and it is, it would be wrong to say that the person is living with cancer. So it's not a bad. And again, if you have that attitude towards life and towards your ailment and towards your treatment, that instead of a battle, it's just a journey, it's probably more easier and enjoyable.
Yeah, well said. What one clinical and one operational solution innovation you wish to be available for you to really make a difference or move the needle in patient clinical outcomes in India?
I think the biggest disease in India is poverty. Access to sources, access to whatever different latest technologies or latest instruments is limited by economic constraints. So if that is not there, I think we would be able to do the best for a person. We always have to tailor or modify and fit the treatment to the patient's economic considerations. So if that is taken out of the equation, we would be able to do a better job. This is what I feel.
Yeah, completely agree. How do you see the impact of 3 to 7 day fasts as cancer prevention strategy long term?
So instead of calling it, only cancer prevention, fasting is a proven technology in which it makes you a better metabolically healthy person. So instead of saying that it is only to avoid cancer, it can be used as a generally good health practice. This is what I would say.
Yeah, and just to reiterate that point, I've written about this topic as well, which is fast is a great way to do a metabolic reset. And since metabolism is the root cause of almost a lot of the evils, correct, it's going to help you across the board. Correct. The only thing I recommend against is doing very long fasts. Right? 3 to 7 days are quite extreme. I think, historically, tradition-wise, we have had a 1 day fast of the week, right?
Right.
I think that's still a more manageable, sustainable tool, because with longer fast, then you have, your protein intake goes down dramatically, you start losing muscle mass. So my recommendation, do the fast, but use it as a tool that is sustainable. A 1 day fast is a week or every 2 weeks is a very good tool.
So one more thing which I have realized, again, maybe not entirely evidence-based, is that it's not only what you eat or how much you eat, it is also how frequently you eat or how less frequently you eat, and what is the distance or the space between your meals. That will affect your metabolism a lot. This is what I've realized from personal experience.
Yeah.
And I think having lesser number of meals and having a certain period of fasting or a certain period of not having anything between the 2 meals definitely goes a long way in maintaining your body weight and being healthy and avoiding excesses of any diseases, metabolic diseases. But definitely helps.
In fact, there was my wife has recently been doing she decides every day how the day went in terms of the number of meals she eats. And she says it's either she's a yogi if she eats only 1 meal a day, a bhogi if she eats 2-3 meals a day, and a rogi if she's eating more than 3 meals a day. So I think that's a nice way to think about it, at least.
Yes.
Very good. I think we are well out of time. Nadia, thank you. She said, thank you, Dr. Amit, for such an informative session. Ashish, we'll make sure the points that you asked for are going to be in the show notes. But I want to just have the community show their love for you, Amit, because it was an amazing session. Very, very informative, very insightful, and I think very actionable. We all, I think, are going to walk away with a few things that we will do differently, thanks to your insights, and the philosophy behind why you were saying what you were saying was as important. So thank you very much, and would love to have you back on the show in maybe 6 months to, because I'm sure there'll be so much more to learn from you.
Yes, why not? Thank you so much for calling me here. I also enjoyed a lot. Thank you very much.
Thank you, Amit. Thank you all. Bye.
Bye-bye.